Hey, good evening, everyone. Shane Shuttlesworth here, president of Osteogenics. Tonight, going to be live with Dr. Ehab Moussa, periodontist, and let me get that invitation to him. Um, and as you guys, as he jumps on, I'll just say if you guys have any questions during the Q&A, ideally this is interactive. Give us your questions. We'll try to get as many of them answered as possible. Hey, there he is. Hey, Ehab, how are you?
How are you?
Good. So right now we've got I see people logging on fast and furiously. It usually takes a couple minutes to kind of get to our maximum group here. Maybe you could just walk us through tell a little bit about yourself. Where are you from? How you came to practice, where you practice now, and just a little bit of background on yourself.
Sure. Well, first off, thank you for finally making this happen. It's a pleasure. I love osteogenics and I love working with y'all, and so it's finally nice to make this happen because we've been talking about it for a while.
Yeah.
So I am originally from Egypt. My father is a prosthodontist in Egypt, and I grew up watching him. He does all his own surgery, so I grew up watching him place his own implants. Um, that got me more interested in surgery, and he would come to the US and lecture to perio residents. And so I came with him once, and saw the perio residents at Case Western Reserve, and I was like, man, I want to learn like these guys. And so I came to the States to do a 6 months fellowship originally, and then go back and join my father in his practice. 6 months turned into a year fellowship. A year of fellowship turned into a residency program. So, 4 years later, I finished residency, and then I feel like, when you're being trained on surgery for so long, you kind of become prosthetically ignorant. And so I wanted to gain some expertise in prosthetics. And obviously, finishing residency, I was literally broke, and I couldn't afford to pay for any more education at Case Western Reserve. So there was this program at LSU University, which is a fantastic program. It's an implant prosthetic fellowship, where they pay you like 35 grand a year, which at the time was like, man, you know, unbelievable. So that's what brought me to New Orleans, where I am right now. I started working as an associate about 2017. And I've been pretty much with the same company. I am now a partner in a DSO here. We have offices between Louisiana and Mississippi practices. Um, this is this is what I do clinically. This is where I work. I currently go between a few offices, and at the same time, um, my passion is also, I have a great passion for education and teaching. And I've had the opportunity along the years to be mentored by great educators, that made me love education even more. And so I have my teaching academy on the side, EM Academy, which we do some hard and soft tissue courses amongst other courses through. And this is pretty much it. My time is, my work is divided between clinical, um, dentistry, and teaching.
Got it. So you practice in in Louisiana? Did I hear that
Yeah.
right?
Yes, I practice in New Orleans, in the
Okay.
New Orleans area. Typically, in the within a 45-minute range, all the practices. Um, yeah, and that's that's
Awesome.
that's pretty much our practice.
So would you ever go back to Egypt or undecided or you're here for good?
Man, I ask myself this question every day. Every day, I'm pretty much, I ask myself the same question. I have my father and my mother, and not much more than that family back in Egypt.
Yeah.
Um, but I feel like I've gotten used to the system of the life and the style of life, and the especially the work,
Hmm.
especially um, the the system of work and how things flow at work. So It'd be kind of difficult, but you know, who knows? Maybe for retirement, go spend a few years by the beach. You know, we have some of the most beautiful beaches in the world in Egypt. That doesn't sound too bad.
Yeah. Awesome. Well, I'm going to jump in a few clinical questions. The audience, as you guys have questions, please put them. You can put them in the chat. I'll be watching the chat. There's also a kind of a speech icon with a question mark in the middle of it on my phone, where you can also put the questions, and we'll see them there, and we'll try to get as many questions answered as possible while we're waiting on a few. I got a few questions of my own. I know that you do a lot with education. You have a soft tissue grafting course coming up in Dallas. Is it April 12th and 13th, I believe?
Yes.
And as I understand, it's sold out. Maybe you could talk about just, do you have more? Are you doing this fairly regularly through the EM Academy? If people can't get into this soft tissue course, when will the next one be? And then as the second part, what draws people to it? What are you teaching?
That's a great question. And there's really, when it comes to soft tissue, I think the more time goes by, the more value we attribute to soft tissue, and the better we understand the importance and the value of soft tissue, especially in implant dentistry. You'll ask a lot of people, if you have an implant in number 8 position, would you rather have great bone or tissue, or great tissue and poor bone? Pretty much everybody who does this on a regular basis will tell you about having bone on the buccal. I care about having good tissue.
Yeah.
And really, when it comes to soft tissue, it's something that's involved in every single aspect of implant dentistry. Like, for example, I'm a firm believer in education, continuing education, and I don't only teach, but I also spend a good time learning. And so this past weekend, for example, I was being mentored by Dan Holtzclaw, who's one of the best zygomatic implants out there. And even with zygomatic implants, there is a great importance in soft tissue, in rotating buccal fat and suturing buccal fat over the exposed large smooth titanium surface. It's really a discipline that falls into every single surgery. And so what we teach in this course, and what I really like about it, is that we don't only teach one technique. We teach multiple techniques, ranging from techniques that you address lack of keratinocyte gingiva in deficient vestibules with like vestibuloplasty, gingival grafts. But we also teach techniques like techniques that add volume to the tissue, like connective tissue grafts and rotated palatal pedicles. But more importantly, we go through, the diagnostics. How do you diagnose a soft tissue defect? How do you treatment plan, decision trees that can help you in treatment planning? And so I really feel that it's, we take the time to go through the whole soft tissue process. So whether you're a beginner, we go through everything from each step of every single technique and through the basics, or maybe you've been doing soft tissue grafting for a while and you want to expand, your scope of techniques that you perform. Thankfully, this course in April, it's been sold out for quite a while. We actually just set a new date for our course. It's going to be in July 18th to 20th. That's going to be a total tissue immersion course, and so it's not only soft tissue, it's soft tissue grafting plus hard tissue grafting. We actually just released that course today, and it's going to be in Dallas, and at the Dallas training facility. And really, again, we spent the first day just going through every single technique and every single part of soft tissue grafting, and day 2 is all hands-on, where we do all these techniques and practice them on pig jaws. And, a lot of people, and I really like to talk about this sometimes, because a lot of people now, a lot of people tell you, what, you don't learn anything from pig jaw courses, you got to do a live patient course. And I don't necessarily disagree with that, that you're definitely going to get a better experience in a live patient course, but you got to know how to do the technique first, right? Before you go try it on a human being, you probably want to try it on a pig jaw, make sure you know the steps, digest it, understand it, then yes, go do a live patient course where you can solidify these techniques. And yeah,
Okay. So the next course, July 18th to 20th, but that's not just soft, that's soft and hard tissue. So that's a 3-day course.
yeah, sure.
Um, gotcha. Um, so as far as, I mean, it sounds like you're doing a lot of different techniques. So this is kind of like an immersion sort of course. I just wonder from a material standpoint, at Osteogenics, we're getting more into the soft tissue. We've been into hard tissue for the last 2 decades, and we're venturing into, really trying to go deep into more soft tissue. And there's an opportunity there market-wise, and it's something that's fascinating, something I love learning about. So, asking a few questions there, like when do you use, autograft versus allograft versus xenograft? Do all those materials have a place in your armamentarium, or is it like, hey, if you can't do an autograft, you're not going to do it? How do you think about the material part?
No, for sure, there is a role for autografts and allografts in my practice. Xenografts, maybe in the past, not so much at the moment, to be
Hmm.
honest. Um, but in general, most of my soft tissue grafting, when it comes to building keratinized gingiva and deepening vestibule, is going to be with autogenous tissue. Um, I personally have not seen a product that would be uh, that I could spot, that I could really say is a substitute for a free gingival graft. I just haven't seen it.
Hmm.
But when it comes to building tissue thickness, when it comes to treating recession defects, I will, I'm a fan of also using alloderm, or using, essentially allografts, acellular dermal matrix. And my preference when I use it is to use it in cases where there's adequate there's an adequate amount of keratinized gingiva, no lack of keratinized gingiva. So if you're dealing with a recession defect in the mandible with minimal keratinized gingiva, maybe I will choose to use an autograft at that point. But cases in the maxilla, especially, you have adequate KG, wide papilla. These are great cases to tunnel using allograft. And obviously, you have find it out definitely when you offer the allograft, you're going to have increased patient acceptance in some cases because some people don't want to use their palate. Um, and in some cases, especially if you're doing multiple teeth, it will probably be a better solution to use an allograft instead of going to harvest an amount of connective tissue and not getting enough or not getting a long enough piece of graft, having trouble suturing it, and then goes south. Um,
Sure.
but yeah, I find there's a role for both autografts and allografts in my practice.
So for root coverage with multiple teeth, for example, would you use a tunneling technique, or would you do open flap? I assume there's some factors where you kind of go one way or the other, but what's your philosophy on that?
Um, it's obviously many factors go into this. Personally, for me, if I am using an allograft, my preference is to I find that using an open flap with an allograft, you have increased risk of exposure of the allograft and possibly infection and other issues. Um, I will prefer to tunnel in cases, where you have wide papilla, um, where you don't have that much exostosis, which may make tunneling challenging. Um, and in other cases, I'm not an only tunneling type of clinician. It's not just a tunnel. Some cases I'll look and I'll feel that the access may be difficult using tunnels. Uh,
Hmm.
Tissue may get torn using tunnels, and then I'll resort to an open flap technique. Sometimes we'll use the laterally closed tunnels, which is a very popular technique, nowadays. And you see beautiful cases from these. I know you've had Fadi and Dimitri on here
Yeah.
before. They do beautiful soft tissue work as well. Um, and so there's plenty of techniques out there right now. Just like a lot of people still look at soft tissue as PG versus FGG, and it's much more than that, because just like you said, are you going to do allograft or are you going to do autograft? Okay, you're going to do autograft. What technique are you going to use? Are you going to coronally position the tissue? Are you going to laterally close the tissue? Are you going to use an open flap? Are you going to do a tunnel? It's just it's a lot of decisions, and to me that's really what makes it exciting, and I feel it's the most creative part of the implant tissue aspect.
From an evidence standpoint, is there, I know especially as a periodontist, you guys pride yourself on being more, like data driven, right? So is there enough data in these different, okay, use this material versus that material, use this technique versus that technique? Like, is it like in bone grafting, it's really hard to come up with a decision tree that everyone can agree with, right? I mean, if I look at a dozen textbooks, I'll see a dozen different decision trees for, and now, you'll find some commonalities. It's not that there's not some alignment, but they branch off in different areas. Is it that way with soft tissue, or do you feel like there's like, we know some things evidence wise that are just facts that can't be argued in terms of, how you treat?
Um, I definitely agree with you on the bone part, because people are gonna base decision trees off of the technique that they personally
Yeah.
can't include in the decision tree a technique that I've done, right? But when it comes to soft tissue, I think that there are certain things that we can agree upon. We can agree on requirements that are needed for soft tissue. For example, around implants, we have to agree that we need thickness. We have to agree that we need sufficient vestibular depth, an adequate amount of not only keratinized tissue but attached tissue. And there's a big difference. And there's a new article by Arno that explains this very nice. So we can agree on things like this. I think in recession effects, we can agree that you will more likely get a improved result using a tunnel approach versus using an open flap approach in a lot of cases, unless your access is going to be limited. So if you feel like you're not going to be able to coronally position the level that you need to using a tunnel, but you will be able to do that using an open flap. But if we go any further, you're going to have a lot of disagreement. So
Yeah.
maybe we'll stop at that. But
Okay.
definitely,
Yeah.
I think we can all agree on the soft tissue requirements and their importance.
Okay. I like that. Um, well, let me ask one more soft tissue question. What's the most common complication that you see in soft tissue grafting? And then second part is, what can we do to prevent it, or maybe it's better to answer, how do we treat it?
Biggest complication.
Yeah, like if I think about bone grafting, I think the biggest complication is around dehiscence. Usually, if you can keep primary closure, the chances of success are pretty high. Is there that kind of equivalent in soft tissue world? Um,
Well, I think, for example, depends on the technique that we're talking about. For example, if we're talking about a free gingival graft, um, what's the most common complication of a free gingival graft, in my opinion? So free gingival graft is a very predictable procedure, but
yeah.
see often is people using grafts that are too small,
Okay.
and we should always remember that whether it's an implant or it's a root surface, you need a graft that will 80 to 90% of it should be lying on a vascular surface, like periosteum or bone, and 10 to 20% lying over an avascular surface, like an implant or a tooth. With recession treatment, um, complications, will typically involve just flap dehiscence also, and
Okay.
is due to, I feel, tying sutures too tight, and the lack of a delicate technique with soft tissue. I feel if you use sutures that are too large, or if you tie your sutures with tension, that will ultimately lead to flap necrosis, and you go back and you haven't gotten the root coverage that you were expected, because what probably you didn't see is at day 2 where you see these sutures digging into the flap and causing areas of necrosis, but you're not seeing the patient at day 2. You're probably seeing them at 1 week or at 2 weeks, where at that time you don't see any of the tissue, and it's like, poof, the tissue's gone. So that, I guess, would be the 2 complications that, in regards to those techniques.
Okay. Yeah, thanks for that. Okay, shifting gears. Another another hot topic for us education wise is around treating peri-implantitis.
Yes.
And we have a course. It's Osteogenics helping host it. You and our mutual friend George Katsakis are teaching it. It's in Mahwah, New Jersey, which is about an hour away from New York City. And that's That's Friday, May 31st to Saturday, June 1st. It's a 2-day course. You're doing day 1, which is more around, and correct me if I'm wrong here, but I believe the agenda is more like around diagnosis and treating implant surface and sort of getting ready for regeneration. I assume you may also talk some about regeneration. And then George's part on day 2 is a little bit more focused on the regeneration protocols. Is that about right?
Yeah, I see my friend, my oral surgeon friend Charlie Sylvia here saying remove and redo. That's his protocol for for peri-implantitis.
Which I hear that all the time, and it's always, if it's your implant, you're cleaning and you're regenerating.
Yeah.
If it's someone else's implant, then you're removing and redoing, right? So,
and really the first person that I saw that spelled that out, I believe it was one of the forum discussions, was Howie Gluckman, and he said, like, one of the biggest factors is, did you place the implant or not? And to be honest, that is a big factor. If you place the implant and you feel your patient is going to turn into a problem, then you're going to do your best to save this implant. But the course with George, I'm very excited about talking about it for a long time, and obviously he has incredible research when it comes with, and again with you guys, when it comes to regeneration and peri-implantitis protocols. But this course is really, day 1 is meant to be about prevention of peri-implantitis, which, as we were just saying, the more the time goes by, we realize the importance of soft tissue, and we have to realize the importance of soft tissue in prevention of peri-implantitis. I can't think, we can disagree on the fact that we need adequate soft tissue thickness, and we need adequate attached tissue width and adequate vestibular depth, and we cannot disagree that all these factors are influential in whether you're going to get peri-implantitis or not. Have tissue that's mobile, that every time the lip moves, the gingival margin is flapping and plaque is able to get under there. You cannot equate that to an implant that has a stable depth of attached tissue surrounding it. So we're going to talk about how you can prevent that by following soft tissue protocols in your cases that will allow you to prevent peri-implantitis. And then on day 2, we're going to talk about when you got the peri-implantitis now and you have the bone loss around your implants. So how do you, what's the protocol to disinfect the implant surface? What's the protocol to get your defect ready for regeneration, and then what the protocol is for the actual regeneration? And I personally look forward to learning that from George, because again, he has incredible research when it comes to this.
Yeah, so. If I think about peri-implantitis, like, well, maybe what is your estimate? I don't know. I mean, there may be data on this. I don't know the number, but what percentage of implants get peri-implantitis? 10%, 20%? If it goes long enough, is it higher than that?
Again, it depends on, whether you're talking about my implants or somebody else's implants. Everybody's going to say that. I think it depends on how you define peri-implantitis. Are you going to define peri-implantitis by just any bone loss that you see on an X-ray, or are you going to define peri-implantitis as having an active disease process where you have pocket depth, where you have probing, where you have bone loss? But I think the percentage is pretty high, and it's probably somewhere between, I would say the 20 to 40%. It's hard to
Okay.
say. There's a lot of research out there that will give multiple numbers. We know when we're talking peri-implant mucositis, which is simply gingival inflammation around an implant, some studies will say about 50%. But
Will you explain that difference to me and any audience members who maybe are fuzzy on the differentiation between peri-implantitis and peri-muco?
you, so, so you can think of it as peri-implantitis of gingivitis, where you have inflammation of gingiva, but you don't have any bone loss.
Mhm.
Or, whether you don't have any loss on an implant and you don't have attachment loss. Well, periodontitis, which is now you have inflammation and you have bone loss. Tooth is the equivalent of peri-implantitis implant, where you have inflammation, have bone loss. And I really think that
Mhm.
for peri-implantitis of the Dr. from Rosen out of New York, that was a really nice paper with some of the best results that I've seen in treating peri-implantitis. And their protocol is honestly what I'm a fan of. And I think it defines peri-implantitis very nicely. It defines it in terms of a percentage of bone loss on the implant surface. And so I think this is a very nice follow in regards to that.
Okay. We got a couple more minutes here. What do you think is the future? Just if you were to guess, what do you think is because treating peri-implantitis, I feel like is this emerging, like there's a lot of people trying to solve this around, surface disinfection as well as regeneration protocols. We have Osteogenics' Advanced Bone Grafting Symposium coming up in Phoenix, April 19th and 20th, and we have 3 or 4 lectures on this by people who are doing research, including Dr. George Katsakis, Amle Wong, Tom Wilson, Isfan Urban are all kind of speaking to what they're doing, what the research says, their regeneration protocols. It's like this. It's a hot topic, right?
Yes.
And so, what do we think is the future of this? Is it implant surfaces? Is it surface density? Is it around surfaces that are just bacteria static? Is it around treatment protocols? Like, do you see is this something that we'll sort of figure it out, kind of best practices, and it'll become more routine, or do we think there's a solution in the future?
Well, I certainly hope so. I certainly hope so that we figure it out more, because what I think we can all agree on is we're definitely going to see a lot more of it as we go. Because it certainly makes sense that as time passes by, more people are placing implants, more teeth are coming out and being replaced by implants. I think the number for all on fours and hybrids is only going to go this way. And we're going to see ourselves in a position where people have lost now all their jawbone because they've had their bone chopped off, they've had all on fours done, and now these implants may be failing. And then, okay, so what now? Now you're talking about the importance of extramaxillary techniques like zygomatic implants and all that stuff. So I definitely hope that we figure out peri-implantitis more, and I think a lot of it will have to do with surface decontamination and having actual and being able to regrow bone predictably around implants, figuring out protocols where we can accurately disinfect the implant surface and provide an environment or provide a particular scaffold that works particularly well in these peri-implant defects.
Yeah. I know it's an area that a lot of people are, there's a lot of investment. It's something Osteogenics is investing in, sort of figuring out, what is the solution. And I know there's a lot of, very smart researchers who are kind of focused on this area. And I feel like we're learning lessons all the time, right? We've learned some things not to do. We've learned some things that work pretty well. And I feel like, this is an evolving area and I think an exciting area, in terms of a challenge worth solving and worth spending energy on. So, well, hey, thanks for your time. Time flies. Time flies. It's already 8:31 my time. Um, Tell us a little bit about the EM Academy, where people can get more information if they want to get more information on your soft tissue grafting courses, your hard and soft tissue grafting courses. You have the course coming up July 18th to 20th in Dallas. Where do they go to find out more information or to register for this?
So they can go to our website, myemacademy.com, or they can go directly to my page on Instagram, and they will find the information right there.
Okay.
Um, this academy, we really focus on providing courses on certain topics, and with every course that we give, the focus is on providing multiple techniques, providing multiple solutions. Even the hard tissue courses where we show techniques with GBR, show techniques, um, like Corey plates, show multiple different techniques, and we focus on the hand part. And for us, having your support as partners really in these hands-on courses um, is really we can't really do it without you, because your support and you think materials that you provide, for example, the glycolon suture, our soft tissue courses are a big part of the hands-on exercises, and so this is where you can find information about our upcoming courses. The July 18th to 20th, that's going to be a soft and hard tissue course. And actually, what's more exciting is that next year we're hopefully launching our first implant continuum, which
Okay.
is going to be a year-long implant continuum that really goes through just the whole 9 yards when it comes to implant dentistry. So that's what I'm very excited about.
Very cool. So it's myemacademy.com or go to your Instagram page, Ehab Moussa, and you'll find information there. Hey, thanks so much for joining us. Appreciate you sharing your knowledge with me and the group that joined us, and look forward to seeing you soon, my friend.
Yes, sir. Thank you. I appreciate you.
Okay. Thanks everyone who joined us. Appreciate it, and good night.
Have a good night.
Bye.